Good afternoon, dear colleagues. Welcome to this live session on autonomic dysfunction is their role for catheter ablation. And it's a great pleasure for me to be joined here by Dr. de Asmundis from Brussels and Dr. Savastano from Italy. And my name is Renate Schnabel from Hamburg, and we will start immediately with a live case. And we will switch to Istanbul in Turkey to Dr. Aksu. I think they are already online there. Hello together. We'll see a live case on cardioneuroablation in a patient with multiple episodes of vasovagal syncope. And Dr. Aksu, I would hand over to you. Hello and good afternoon.
Hi everyone. I hope you can hear me very well.
Yes, we do.
Thank you. Everyone, welcome from Istanbul to all of you. Today we will try to present the new era on GP mapping during cardioneuroablation, and we will try to demonstrate combination of 3D mapping and 3D CT merge to map ganglionated plexus during our cardioneuroablation procedure. My team will briefly present the case. Today's case, a classical vasovagal syncope case, and then I will try to show you what we did so far. So let's see our 3D mapping data. What we did, we mapped right and left atrium, and we used firstly fractionation mapping software to calculate the fragmented electrogram by using a software. And this map, white area shows electrogram more than 2 deflections. You see the left superior GP, our ablation catheter contact in there. Please remove the left lateral view. Turn to left lateral, sol lateral lütfen. And you are seeing the Marshall tract GP area and posterior wall, please. You are seeing the left inferior GP in the left panel. And then, please, anterior posterior view and a little bit more left anterior oblique. Can you increase the translucency of right atrial map, please? Yep. Now you are seeing the right superior GP clearly. Now we will add peak frequency mapping to fractionation mapping to decrease the GP, our target area. Let's add the fractionation and peak frequency mapping in the same way. Can you demonstrate the left superior GP area? Now, white area shows the site more than 2 deflections and frequency is more than 400 Hz. So now we will combine our CT spaceman, 3D CT spaceman, please. Let's see what we are seeing in CT in that area. Can we increase the translucency of left atrial map? Yes. Please remove the 3D map. Sol atriumun ve sağ atrium 3D map'ini çıkar. Just we'll see CT distribution of GP. Can you add left and right atrial map on CT, please? Yes. You are seeing the distribution of epicardial fat pattern, of course, GP based on CT spaceman. Now I will remove the CT. Again, please add the 3D map. Okay, add GP map on CT. All of them shows these area as the main target, and at the bottom of the left panel, you are seeing the distal tip of our ablation catheter. We are on left superior GP side. You are seeing our contact. 7 gram now, and we will start to ablation. In usually, we want to see a little bit bradycardia or maybe asystole during ablation on left superior GP side. Let's start. 35 watt we will use. 35 değil mi? Heart rate is 60 BPM. We are keeping ablation at least 20 minutes in the same area, and we are checking the EGM. We didn't see any vagal response. Again, this is, can you remove the CT-GP? Just show me 3D map, please. Okay. Look at that. We are in the peak frequency and fractionation mapping area for left superior GP. This is the second RF application. Again, there is no vagal response, so I will keep the other side for GPS. Okay. I am in the right side. Just a little bit bradycardia, not too much bradycardic response. By the way, we are using general anesthesia to prevent any movement of the patient. So usually general anesthesia causing a little bit blunting of vagal responses. But I didn't see any vagal response. Our ablation area. Just maybe 20% decrease on cycle length. So this will be the last station. Last ablation point for left superior GP. We are trying to ablate all peak frequency and fractionation site. Yes. Here we go. I'm trying to increase the contact.
So if I may ask...
yes, you can see the bradycardia, heart rate decreasing.
Oh, maybe you can.
Yes. You can see that. So we will keep on the ablation and we will try to decrease all vagal response in the same area.
Can we make a question?
Sorry?
Can we make a question?
Okay, of course.
What are your procedural outcomes? What is your endpoint here that you say, now I've put in enough energy, or if you have...
Our ablation endpoint will be elimination of fragmented electrogram in the ablation area. If we see vagal response like the previous one, we will also try to eliminate this vagal response as well. If you ask any question about extracardiac vagal stimulation, we don't use extracardiac vagal stimulation because extracardiac vagal stimulation only shows parasympathetic innervation effect on sinoatrial node and AV node area. So just performing ablation in this area, you can eliminate extracardiac vagal stimulation and you cannot see anything about the EGP site. So look at that. We ablated this site and there is no electrogram in the same site. In the first RF attempt, we decreased heart rate from 60 or 65 BPM to 40 BPM. And now I will apply another application in the same site. There is no electrogram in the distal tip of ablation catheter. And there is no new bradycardia during ablation with the same power. So we finished our work in left superior GP. Okay? And according to CT, there was nothing on Marshall tract site or left inferior GP site. Please turn back the map. But posterior döner misin? But look at that. According to CT, we didn't see anything in this left inferior GP site, but according to peak frequency and fractionation mapping, and based on my visual analysis on electrogram on this distal tip of ablation catheter, we are seeing fragmentation on this side. So I will perform RF application. Let me increase the contact a little bit more. Yes. Okay. Kontağı görebilir miyiz? Okay. You are seeing fragmentation on electrogram on distal tip of ablation catheter. Also, we are seeing white color in that side, left inferior GP area, and I started the ablation. We eliminate the electrogram, but there is no vagal response. This is very, very tiny GP side, and you cannot see anything on CT. But according to our classical approach, we are performing ablation in that side as well. If we are seeing any vagal response, our second ablation endpoint will be elimination of this vagal response. Again, it's same in this all GP sites.
Sorry, I have one question. Do you perform the case always in general anesthesia or local anesthesia?
Both of them. Actually, if I want to see vagal response clearly, I prefer local anesthesia or multi-sedation, but it is not easy to map clear in such a situation because it can cause serious pain and the patient move too much. Especially, you know, vasovagal syncopation is a very difficult population. So I suggest to use general anesthesia. So we just see decrease from 60 BPM to 50 BPM level heart rate. So in the second or third RF application, I didn't see any bradycardia. We eliminated electrogram. So I will move to right superior GP. Heart rate is still 60 BPM level. Can you remove the right atrial map? Yes. White side shows fragmented electrogram and peak frequency electrogram higher than 600 Hertz. And please add CT GP. Transustansiyı azalt biraz. Yes. CT, our map shows the same area here. And please look at the electrogram on left panel. You are seeing clear fragmentation. Heart rate is 60 BPM and I will start the ablation. We already checked the phrenic nerve and it's, as you see on CT, it's far from our ablation area. So I will start the ablation. Heart rate is 57 or 60 BPM level. Increasing 70.
Sorry, the position of the phrenic nerve, do you confirm with pacing during the map or not?
Actually, we usually, if it's very close on CT, we are performing high amplitude phrenic capture and checking. But in this particular case, it's far from our ablation area. Look at that. We just performed one RF point and now heart rate is 84 BPM level. So now if I use extracardiac vagal stimulation and after just one RF point, I can eliminate this extravagal stimulation response. Why? Because now we just ablated parasympathetic fibers to sinoatrial node. We didn't ablate epicardial ganglia. So this is why we need a better procedural endpoint to map GP and to decide procedural endpoint. Okay? So I already increased the heart rate, but I didn't finish my work. I will try to ablate all fragmented electrogram in that side.
Do you start always from the left side?
Yes.
And you always do right and left side, or do you, in some patients, do right first and then see what the outcome is?
Actually, very good question. In all cases, I perform bilateral ablation for right superior GP side. Okay. Because this is the most important and the biggest GP according to anatomical specimen. So we ablate, biatrial ablate right superior GP in all cases to prevent reinnervation.
And after the procedure, in the follow-up, how long do you anticoagulate? I guess you anticoagulate patients when you discharge them.
Yeah.
For how long do you do this?
Usually 2 months.
2 months. Okay.
Yep.
And how do you follow up your patients? By symptoms only, Holter ECG, or?
Actually, we always try to check Holter recording at 1 month and then 6 months and then 12 months. Usually for procedural aim, research aim, because we would like to see the heart rate variability parameters during follow-up as well, and try to find whether there is any difference for reinnervation. For example, in some patients, we don't see any GP in left inferior or Marshall tract side, so we will pass this station. And I would like to compare the follow-up results of whole GP ablation patients and partial GP ablation patients. But I think that for vasovagal syncope patient, the most important thing to follow the symptoms of the patient.
Yeah.
For example, after ablation, we don't see any new syncope, but then after 2 or 3 years, the patients say, I have some prodromal symptoms, and we are checking tilt test again. For example, usually we see vasodepressor response during follow-up. So in such a patient, we prescribe midodrine or something like that to prevent new syncope or new prodromal symptoms.
Okay, are there questions from the audience? Please, you can get up to the microphone, or you can put in questions online, which we monitor here. So please feel free to interact, to ask questions to the operator.
I have one question. Do you only use radio frequency?
Yes. You mean for cryo or?
Yes.
Yeah, during cryoballoon, of course, based on the contact point of right superior pulmonary vena and vena cava superior, of course, you can eliminate some of right superior GP, some epicardial ganglion, right superior GP side, but of course, the best way to use 3D map. But if you are talking about pulse field energy, during endocardial ablation, you can just cause some partial response during PFA, but you will not damage epicardial ganglia.
Okay.
There's
Hello?
a question from the audience.
Doc, this is Juan Serpa. How are you doing? Nice
Hi,
seeing
my
you
friend.
do
Good,
this
good.
elegant way to do a cardioneuroablation, including CT image and also electroanatomical mapping. We always disagree on this. I think only one application of radiofrequency won't eliminate the extracardiac vagal stimulation at this point. You're going to need more transmural and more effect on this just to find it. And this is an endpoint that we're using just to follow these patients, even with long-term follow-up. What I think is really useful with this approach with anatomical, did you try to see the sinus node artery with the CT on this point? Just to thinking
Actually,
if you need to go bilateral or something?
Yeah. Actually, my previous match on CT, yes, I already saw the localization of sinoatrial node artery, but we couldn't merge. I couldn't understand why. In the previous case, I checked, can you add the arteries on CT? Let
Maybe
me check
sometimes it's
again.
too little that you cannot put
TNA'yı da ekle lütfen. Göstersene yukarıdan.
Yes, I think. Yeah. Okay, I think for the time being we have to move on the next presentation, but we keep online to see the final result, or if you want, back to Istanbul to see the result.
Hi everyone again. We now we mapped, we ablated left atrial and right atrial part of right superior GP. Please remove left atrial map to see our ablation for right superior GP via superior vena cava. Yes. Look at that. There is no EGM, and please add epicardial GP on CT spaceman as well? Yes, you are seeing we ablated right superior GP via both left atrium and right atrium. Final heart rate is 80 BPM level at the beginning of the procedure. Heart rate was 58 and now 80 BPM level. We didn't apply atropine. Now we wait just for you. Please, atropine. We will apply 2 milligram atropine to see whether there is any change on heart rate or AV PR interval or something like that. And you are seeing we ablated left superior GP. Can you show with arrow, please? Left superior GP site. Sol superior GP yaptığımız yeri göster okla. Yes, this is the left superior GP. You are seeing on CT specimen as well. We also ablated right superior GP via both left and right atrium, and by pullback our ablation catheter, we also ablated right inferior GP. Please see from the posterior anterior view. Yes, and can you add left atrial map? Okay, so remove the CT spaceman. By the way, we used CT of in-heart system for this 3D map images. This perfect images. So can we see the left superior GP from the upper part of the left atrium? Yes. We combined CT, fractionation mapping and peak frequency, and we ablated this area for left superior GP. And please turn to posterior anterior view, PAO. And ortaya getir görüntüyü abi biraz. Left inferior'u göreceğiz. Hayır, left inferior. Left inferior. Getir biraz. Evet. Can you okla göster. Left inferior. Evet. This is the left inferior GP by combining fractionation and peak frequency. We decided at this point we didn't see anything on CT because this is a very tiny GP, but both peak frequency and fractionation mapping shows the same area, and we also saw fragmented electrogram on that side, so we ablated this side as well. And please çıkartalım sağ atriumu. Önden gösterelim. And this is the ablation point for right superior GP. Yes. And birazcık kaldır haritayı. Ve septali göster. And this is, we just performed 2 ablation point for right inferior GP. Please add the CT. Yes, CT also shows the same area for right superior GP and right inferior GP. Of course, CT shows us to epicardial fat pad, and we already know that throughout the epicardial fat pad there is no GP. So epicardial fat pad is not synonym with GP, but you are seeing a very, very good correlation between peak frequency, fractionation, fragmentation on electrogram, and CT spaceman. And we didn't see any response after 2 milligram atropine administration. Heart rate is still same. So we finished our procedure.
Yeah, fantastic. Thank you very much for taking us through this elegant procedure in almost no time. How long did it take you? This is not a routine procedure, of course, but it's a live case. So half an hour, is this your regular time that you need for such procedures?
Yeah.
Yeah, very elegant. Thank you again.
Thank you very much.
We enjoyed it
Thanks
very
so
much, and we are now disconnect. Thank you, the team and the patient. Thank you.
Thank you.